So what I was saying is I worked as a GP for a number of years generally in inner city areas, and throughout that time what was really clear to me was the massive contribution that people's social circumstances make to their health, and I hope that resonates with what we've heard this morning, particularly in the first talk. And really on the back of that I decided to move sideways into research, and at the moment I'm funded by the ESRC and I'm undertaking a PhD looking at primary care social prescribing, and I'm sure that a lot of you here today will have heard of social prescribing and you may well know more than I do about it. What I'm going to do is talk a little bit about what social prescribing is in case there are people here who haven't heard of it, and then I'll tell you a little bit specifically about my PhD project. So social prescribing is a way of facilitating primary care staff to refer patients for non-medical solutions to improve their health and well-being. So it really is about helping patients access non-medical solutions to things going on in their life that might be influencing their health and well-being. So really addressing socioeconomic and psychosocial circumstances. It generally involves a link worker model whereby a primary care staff member, which could be a GP, a HCA, a practice nurse, refers an individual to a link worker who sits down with them usually for about an hour or so and co-produces a social prescription identifying areas in their life that are impacting their health and looking for solutions, usually by engaging with voluntary and third sector organisations that will address those circumstances. So it could be things that we've heard about this morning, it could be cookery classes, it could be exercise, it could be group activities, it could also include things like welfare and benefits advice. So it's a very broad spectrum. It is very popular at the minute. Really the popularity is in newspapers, magazines, as well as the academic literature. So it's difficult to pick up a newspaper without reading about social prescribing. I think the reason for that is it's so many things to many people. So I think originally it was seen as a way of tackling social determinants, a way of tackling health inequalities, but I think also now it's seen as a way of reducing the number of prescriptions, reducing medicalisation, and also reducing system level pressures, so practically reducing the number of GP appointments, the number of A&E attendances as well, and also tackling health behaviours. So I think different people view it as different in terms of what it can achieve. As I say, it is increasing in popularity, but the evidence base for it is actually lagging behind that popularity and that surge in policy interest. And some of the reasons for that are highlighted in a paper that came out earlier this month, the author of which is actually here today, so he's probably better equipped to tell you. But essentially, social prescribing is a very difficult thing to conceptualize. There's a lack of theory around what it actually does, what it actually is. And it's very diverse, so often schemes pop up organically driven by local context, so they have different aims and different outcomes and target very different populations. So models of social prescribing are hugely variable. So choosing outcome measures that you can compare across interventions and say, yes, social prescribing works, is actually very difficult because at the moment, nobody can really pinpoint what constitutes success in relation to social prescribing. In response to that difficulty, NHS England have drafted a common outcomes framework, and in that they've identified 3 potential areas in which social prescribing can have an impact. So on the individual, on the individual who has been referred and potentially their carers and families, also on the community, so building community capital and really tapping into resources within the community. And finally, as I touched on, impacting on health and care systems, so systemic level changes in appointment rates. But it's not just efficacy. So if we're going to refer people to social prescribing interventions, we need to know that they're going to engage. And what we do know from the research is that patient engagement does vary, and we're just starting to understand some of the factors that influence whether patients engage with it or not. And what we know less about is whether GPs engage. So there are hugely variable rates of referral amongst different GPs, and we're just trying to understand why that is, why some are very keen on social prescribing and others maybe engage with it less well than their colleagues. So in summary, we have a poor conceptual understanding of social prescribing with varying constructs of success and failure and differential staff and patient engagement. So I'm going to talk to you a little bit about my PhD, which is really focusing more on the primary care engagement, trying to understand what influences whether or not GPs engage with social prescribing as an alternative to the more traditional medical models of managing patients' health and well-being. So I've chosen ethnographic methodology for my PhD. So ethnography is a methodology rooted in anthropology and really relies on participant observation. So it's a long-term and immersive methodology that involves spending time in a particular environment and just exploring the complexity and the context of the phenomenon you're interested in. And it's iterative and responsive, so it's very good at exploring how knowledge is created around a new phenomenon. So with social prescribing, it's interesting to explore how knowledge is being created, how it's being talked about, and what factors influence that. So my specific research questions are: how is knowledge of social prescribing created within and by primary care teams, and what influences this? How do primary care teams construct concepts of success and failure in relation to social prescribing? And how are social prescribing routines embedded in the daily practices of primary care staff? So as I said, I'm doing an ethnography which involves largely participant observation. When I say participants, I mean primary care staff. So at the moment I'm sitting in GP surgeries, observing consultations, observing staff talk about social prescribing, observing the referral process. And I've also got ethical approval to interview primary care staff and interview patients. And really, with the ethnography, it's about triangulating what you watch people doing, what they tell you they're doing, and what other people tell you they're doing. So it's quite powerful to be able to incorporate those three perspectives. So I'm hoping to spend time in 3 to 4 different GP practices accessing a local social prescribing intervention. The intervention I'm collaborating with is called Ways to Wellness. It's established in West Newcastle upon Tyne. It's accessed by 17 local GP practices and supports people with long-term conditions who may also be experiencing depression and anxiety. And I think it's worth saying that it's based on a social impact bond investment. So I'm about 2 months now into my data collection, so it's much too early for me to present you with any conclusions or any themes, but what I did want to do was just present a few extracts from my early data, which I hope gives a flavour of the sorts of things that might be relevant to explore in future in relation to this. So this is an extract from my field notes when I attended a GP practice meeting where the GP practice staff meet before the surgery in the morning, and they were discussing casually social prescribing. GP1 asked how people raised it in consultations, and the practice nurse said she asked if people needed help. Were they socially isolated? They need help with forms. GP1 joked that if you say, do you want exercise or to lose weight, the answer will always be no. But if you say, we have this fantastic service, we can change your blood pressure tablets, but these people can talk to you about all the other things that are important to you. GP3 agreed enthusiasm was important, but for that you need feedback to know it was working. I think this quote is from a session where I was sitting on a routine surgery with a GP, and I think it taps into his perceptions around social prescribing, addressing some of the complexity that patients are faced with. So after the patient had left, the doctor explained that she was not eligible for Ways to Wellness, but her husband had been referred. It was often the way, he added, that one member of the family may be eligible, and so they get in, but they sort everyone out. So this was a family of very complex social circumstances. There were children in the home as well. So really one member of the family accessing the intervention allowed the link worker to go in and assess the needs of the whole family. The next 2 extracts are taken from consultations where the patients were offered referral and both declined. So it's really worth remembering that these are patients who are eligible for the referral, so they'll have at least one chronic long-term condition. The practice nurse asked the patient if he was going to retire, but he explained how he couldn't afford it. He got state pension, but it wasn't enough. What about other benefits? Practice nurse asked. Shall I get someone to come and talk to you? Meaning Ways to Wellness. No, said the patient, I'll just leave it as I am. So that patient declined referral when it was very much framed in the terms of welfare advice. This referral discussion had very much around lifestyle intervention, so it just shows how the intervention can be framed differently in different circumstances. So the doctor spoke a bit about raised blood sugar, saying it could be due to diet or alcohol. She asked the patient if she knew she was borderline diabetic. Yes, borderline, the patient replied. Who's at home? Asked Dr. Six. I'm on my own, the patient replied. Her daughter, she added, lived in the same street. Would you like some help organising exercise classes? The GP asked, to which the patient replied that she lived in a big house and went up and down the stairs all day. How's your diet? All right, said the patient. If you need more help organising things like exercise classes, we can offer help with that. So as you can see, it's not always offered as social prescribing, and it's not always offered to reflect what the social prescribing community may necessarily intend social prescribing to achieve. This is another example which I think it does reflect how this GP does conceive of social prescribing as something that addresses more complex social circumstances and as an alternative to medication. This patient had already been referred to the intervention and had a very positive experience and was having ongoing input from the link worker. The patient was already seeing the link worker from Ways to Wellness. He'd had help from her mainly to lose weight. As he described his situation, the patient explained how he felt the loss of his work. And with universal credit, he added, well, I just can't see the light. So much of what is causing your stress is rooted in this situation you're in, and there's no tablet for that, said the GP. So early impressions, as I say, I can't draw themes based on the data at this stage, but I hope that those extracts give a flavour for how referral practices can really give insight into how staff conceptualise social prescribing and how it can be either seen as a lifestyle intervention or something to tackle these more complex social circumstances. And I also hope to explore further how the way that staff introduce social prescription may influence whether or not patients decide to engage with it. And finally, just from my early experience in the field, there are other factors that I'm hoping to explore in a bit more detail. I think certainly in primary care from a staff perspective, funding models for social prescribing, how eligibility criteria are decided, and whether or not there's good feedback are all seemingly quite important issues for staff when they discuss social prescribing. So that's all I'm going to say today, but thank you very much for listening, and I'll be happy to answer any questions later on. And if anybody's interested,